today is going to be sent in small groups, so it won't matter as much. But I'm going to stand over closer to this puck so that people on Zoom can hear me. So we'll just welcome you. I want to first shift to Nancy, and so that she can give your subcommittee. She was able to update the main task force, gosh, it was just last week, on the work of the safety net subcommittee and start kind of getting some information back for them. So I thought as a welcome, she could kind of give a little overview of how that went last week. So Nancy, can I ask a favor that you come close to Emma, and then the people on the phone will be able to hear you a little bit better. Or Emma could go to either way.
Well, hi, everybody. It's good to see you all. And I'm glad everybody found this place and found a place to park. Although Pooja got to walk over, so that's kind of unfair. But anyway, nice to see everybody. And so, yeah, I went to, although I missed our meeting, I did go to the Behavioral Health Task Force. And I first of all, just say that I was really impressed when the different committees reported out. The task force was really engaged and asked lots of questions. I thought, you know, you just give your report, read the slides, and then they, you know, let us go on. But no, they just really asked a lot of questions and so on. So when it came time for our report out, I mostly just talked about what we had done, you know, trying to define, come up with the definition of stakeholder. I talked a little bit about how we had struggled with nomenclature in terms of individuals with rather than, forgive the term, crazy people or patients or something else. So individuals with some condition. So I talked a little bit about that. And then unfortunately or fortunately, we said, what would you like us to do? What would you like to see from us? And so I have a laundry list. All right. So they were really engaged in the conversation. So some of this stuff we've already talked about. Okay. But just so you know that I think we're thinking on the same page here. Access and long wait times is an issue for them. Detox services is an issue. Crisis stabilization is an issue. Someone mentioned that behavioral health is rationed more than medical care. I thought that was an interesting concept, the concept of rationing behavioral health. You know, you get 3 visits and that's it. If you have cancer, they don't tell you that. There are gaps in the crisis services. There's a feeling that they're really happy that we have some, but there are gaps. They'd like to see the parity law have some teeth in it. That there's, you know, there have been laws about parity, but it hasn't come to fruition. So if we had some teeth to that. They asked about subcommittees, and I think the response about having subcommittees was let's frame it as work groups. Maybe within our committees, perhaps we could have some work groups working on specific areas. Let's see. They asked us to think about oppressed populations. Perhaps we should have an equity committee or an equity subgroup. Older adults, folks with dementia were mentioned as a special subgroup. So there's a lot of special groups, and that became really, really clear as people spoke, that there's a lot of different diagnoses and a lot of different ages or ethnicities that all felt like there should be special attention to that group. So somehow, how do we handle that? How do we get a hold of that? Looking at data and so on, payment models with respect to access. How do we pay for care? Let's see, prevention and lower levels of acuity, culture changes, Housing came up. And overprescribing by doctors. So those were some of the issues that they came up with. So nice long laundry list. I'm not sure that they said anything that we haven't really kind of at least touched upon a little bit. But as I said earlier, I think it's good to know that we're all on the same page. We're all thinking of the same problems. The same problems are all over the state, different degrees, different emphases. But there's lots of people who are not getting the care that they should get, or that they are entitled to, or that we would like to see. So our work is cut out for us. I think we might want to think through at some point this idea of work groups, or how we handle these special populations, if you will, aging folks, folks with dementia, for example, different ethnicities and so on, different cultures. There's a lot of different diagnoses. Do we handle that differently, or do we do a kind of a transcendent, kind of overarching, this is just a basic level of safety net, and then tackle these groups in smaller working groups in some way? That's something that we might want to think through and make a suggestion on. So,
Great.
Did I cover it?
Yeah, oh, there's a question. Right?
A question, yes, sir.
Yeah. Did the task force talk about any feedback they're getting from the public?
About what?
About the public forums of the town and the feedback that they're getting from?
Oh, they just had one, I think.
I think there had been 2 opportunities for public testimony, and we were actually able to watch one of them. It was very moving, from a family. I can't remember where they were from. But I think they're going well. I think they've been, it's been a way, I mean, Summer has been in all of them. She just said it's just such a nice way to connect with how this comes down to people. Like, we get disconnected from that. And I know that they are available on the website that the communications team has posted the recordings of the testimonies.
But are they ever going to start tallying up what they're hearing as a common theme, especially with gaps and breakdown? Because I went to one of them, and there's a lot of, it's very interesting to hear from the people that have actually been in the mental health system, and where the mental health system, where it broke down was bad. Because if we hear that back from the actual users, then we can start looking at maybe possible solutions. Are they ever going to put that down where we can start seeing maybe some written feedback from these?
I don't know. And Summer is on her way to Greece right now, but Robert is saying yes. So I'm not really sure how that is being compiled and how that's being analyzed, but I don't know. Summer's gonna figure it out. So yeah, and so we can follow up with her about timeline on that, and when we can try to reconnect it back to the subcommittees. Any other questions for Nancy about the task force meeting? Yeah, go ahead.
In terms of access, did they ever mention workforce? Because that was one of the topics that came up at our last meeting. It was, workforce in relation to
I have
that.
to admit, don't remember.
They did, and maybe not so much as direction to Nancy for the safety net committee,
Mhm.
but the main task force is definitely planning the next time to really get into focus work groups, and one of them is related to workforce. And so kind of, since it's sort of this overarching issue across all of the subcommittees, they're thinking it's probably something that the main task force will start to really think through.
I picked up a couple of metaphors, and one that I particularly liked was the spaghetti system. That they felt that we need to do some coordination between all the systems, that lots of players, lots of people doing stuff, but we don't know exactly how these pieces interact and so on. And so that was also mentioned. So there's just a lot of different pieces, and I think in some way or fashion we're going to have to kind of separate that out, what the issues are, and kind of fill in the gaps.
Robert, is there anything else you want to add to open? I'm going to have you all do introductions in your small group so that you can just kind of get launched into that versus going around the room today. But is there anything else you wanted to say hi? Okay. So really what we're going to do today is spend most of our time, like I was saying, in the small groups that you're in now, to really begin to build out this idea of the safety net continuum of services in Colorado. And so just as a reminder kind of where we are, we're trying to figure out how to move through the next several months. We're working on this array of services today. I think it's probably going to take more than 2 hours of this group coming together to really think about what is the current state, what is the ideal state, where are the gaps. Some of that will start pointing at what Nancy's been asked to think through from the main task force. So if we don't get through it all today, that's okay. I would be shocked if we did, but it's an opportunity to really dig in and get started. The minutes were posted after the agenda went out last week, so we're not going to approve them today. We're going to give you a chance to actually look at them and revisit it in 2 weeks, and we can approve the minutes from September 5th when we're back together again. So with that, I'm going to pass to Jonathan. So he's going to just do a little tiny recap to get you warmed up and thinking through what we're going to be asking you to think about today related to what we did last time we were together, and then we'll set you loose.
Sounds good. Hi, everybody. Again, I'm Jonathan Muther with the Farley Center. And so we just wanted to give you a little bit of an overview of the task today. And as Stephanie said, recap from last meeting, even though I personally happen to not be here. I'll do my best to put together what you guys talked about. Again, this is what we call internally on the Farley team, the protractor, but this is a spectrum of care from promotion to prevention to treatment and recovery. And obviously there's a whole lot of detail that needs to be filled in across this spectrum of care or service array. And that's what we're going to task you with today. There's 2 worksheets that hopefully everyone has, and please let us know if you don't have them. In addition to this visual that we'll leave up throughout the small discussion groups, there is SAMHSA's definition of the ideal service array that I think we pulled actually from the Witchy report, or it's the same one that was used in the Witchy report, I think. It is. And so we're going to ask you to take a look at that in terms of what is the existing, or per SAMHSA, what does the existing service array look like? And then you also have a blank worksheet that is the same structure, and we're going to ask you to fill in some gaps. And so you should have a worksheet also with some questions that we're going to ask you to think about. So in addition to, or separate from, SAMHSA's ideal continuum, we want you guys to discuss what also exists in Colorado, either by service line or type of service encounter, or type of specific service like psychotherapy, or a program that's working well. So help me with so assertive community treatment, for example, as a program. So we want you to map out what exists in Colorado to kind of fill in, again, where do we meet the SAMHSA standards, and what do we have in addition to that. We're also going to ask you to talk about the gaps, or what has SAMHSA put out there that may be missing, or maybe not exist to the standard that should exist in Colorado, or to the extent. So we're going to ask you what exists, also what are the gaps. We also ask to think about what are the points of duplication. So what kind of services are missing, and where across the service spectrum might there be redundancies? And then also along the way, collectively, what's working well and what's not working well. So I'll stop there. Does that all make sense? And does the task for the subgroup seem clear? The questions are laid out. There's 4 or 5 questions, A through E, that are not necessarily linear for you all as a group. We'll ask you to kind of think about those things as a collective as you're sharing your thoughts and going through the discussion today. So whereas this is a kind of super high level overarching guide, We want to get down to even more specifics and really pretty granular with service lines and/or programs to again lay out what's out there, what's working well, where are the gaps, where are the points of redundancy or duplication, in order to change kind of or capitalize and create an ideal service array across the board.
And I would probably just add that the SAMHSA continuum is thinking of a full ideal behavioral health system, and the task today is really focusing on safety net services. And so there are some things, depending on group discussion, that you may want to highlight or exemplify for safety net system. And
so SAMHSA, the full continuum is it's all populations.
Yes.
And all payers.
Yep.
I didn't hear,
So-
what are we supposed to focus on? I'm sorry, I couldn't hear.
Safety net.
Yeah, so just kind of thinking about the population that we have used as our definition of safety net, kind of keeping it within those boundaries. And the children's subcommittee is doing a similar exercise related to kids. And so we can not worry as much about them. So just kind of thinking about who we're representing as the safety net subcommittee. From a process perspective, I realize this is really little. If it's easier for a recorder to do something on a laptop that you send back to me and Emma later on today or later this week, any way you want to take notes that makes sense to your group is totally fine with me. If you want to use the flip charts, if you want to use this, if you want to type, whatever, just as long as we're capturing all this information, because we'll take it back and try to put it together across the subgroups. And there's going to be some people who are joining by Zoom who will be doing the same. Are there any other questions? We'll be at each, one of us will be at each of your groups to help kind of get you launched too. Yeah.
Enough guests and stakeholders so they can have their own group?
I think we don't. We only have 2. And so I'm going to just have them probably join groups that are one of your groups, if that's okay. Because otherwise it's just you guys. Okay?
And I would imagine that a few of us are not going to know, as far as like where there are gaps, or so I just, I think part of the exercise would be identifying where as a task force we need more information about specific areas.
We tried to mix you up. That's why we assigned you groups. We tried to kind of mix you up into teams that would be able to help think through things from different perspectives. But yes, I think there'll probably be places where we still have gaps that we need to think more about. All right. I expect it's going to go from silence to very noisy. That would be a good sign. If you have questions, just come find us. So we'll be. I'm with you guys. You guys get me. And Jonathan's back here. Who's is here. And if you guys want to just join any of the groups, you're more than welcome. No, any of them.
It seems like the state does know what.
I think you said earlier, but let's try to keep the same groups together for a couple meetings.
Okay.
And we can, there's no way.
Yeah, so that makes sense. And it
Right.
seems like it was a good conversation. So would you guys mind going first? My group, group number 2, just kind of a general report out to the group.
Sure. So we did not get very far, but we had a lot of good conversation. I think some of the things that we talked quite a bit about healthcare, homes, and physical health, particularly the intersection of behavioral health into primary care, and some nice models where there's robust screening in primary cares. Sometimes there can be a gap in terms of what happens after that screening, and so linking to ongoing care can be a challenge. We talked about the 6 sessions covered under Medicaid when provided in primary care, which can expand access, but then what happens after the 6 sessions, particularly in rural counties where there's not a lot of more intensive services available after that. We talked about, and I'm skipping over some things, group chime in if you'd like to. In terms of prevention, we talked about the importance of peer support and utilizing peers when responding to community crises. We talked about co-responder models and collaborating behavioral health professionals with deputies and responding to emergencies and trying to prevent hospitalization or other more intensive outcomes that may not be necessary. Mental health first aid, crisis intervention training. There were a couple of examples of other supports that were really helpful, so we jumped around at this point. But things like the Ronald McDonald House and Open Door Ministries, where people really can come into a welcoming environment and just have whatever their needs are met, whether it's a shower or a meal or a yoga class or some time for the kids to play, and how those services and other supports can be very helpful. In terms of acute intensive services, we talked about some possibilities with 911 response and working with dispatch to connect, to identify and deploy the appropriate resources from a single sort of point, and linking that potentially with crisis line. And the Office of Homelessness Initiative through DOLA, the by name list or coordinated entry, where we were really focusing on addressing the needs of the highest risk, highest needs population in terms of wrapping around care. A lot of discussion in general across all of those categories about how the services that exist along this continuum do not exist across all of Colorado with the same level or intensity, particularly in some rural or mountain communities where there may not be the same level of access to all of these.
I think one thing from my group that I would love to see is some homework that I might tap you for in the next week or so is examples that you cited around peer support services in other states and how they're paid for, to kind of think if there's ways to model and scale some of that. You what? Am I listening? We're on it.
For other reasons.
You guys got stuck retaining, so I feel bad for you. How about group number 1? Emma's wondering with the mic.
No pressure. Okay, well, so we went about this process in a very non-linear fashion, so not as organized as your group, but still very, very fruitful conversation. So we kind of started off just kind of talking about things that worked and didn't work, and then trends within the things that did work, kind of what were those characteristics between the different things that we talked about that kind of were in common. So we talked about how, so in terms of gaps, we talked about how the state needed to be better at competency restoration, specifically in terms of looking at how a lot of different divisions and areas have different hospitals, and a lot of times there's not an overall entity or governing board telling these individuals how to interpret certain regulations, so having a standardization process in place. Another thing we talked about a lot was a huge barrier in terms of funding trees. Since funding trees are not shared, it's not as effective. And so a lot of times there's individuals that fall through these gaps because, for example, DDS services have different funding. And so you have individuals that are not able to receive certain services. Something good that came up was RAISE, and that was talked about a lot. It was a way to get better services individually, but a downside in terms of something that we talked about was every single RAISE interprets kind of standards differently, so that's a gap, kind of how we mentioned earlier as well. So having an overarching governing board telling RAISE how to interpret these or standardizing it at the state level would be something. And then in terms of what else did we talk about? Things that worked, care teams to help solve the overuse of the system. So co-responder teams, having them funded through different funding streams has been helpful. And then Colorado Springs Centennial were some examples that were brought up. Model of mobile responses are really helpful because they're community-based and money is already there. Individuals can identify people within communities that are already knowing the populations that may be at risk for certain issues. Team approaches are really good. What else did we talk about? The Circles program in Pueblo was talked about as something that works well. Navigators, having something that's kind of a warm handoff to care. The 24-hour crisis hotline was something we talked about as something that was beneficial. Partial hospitalization and intensive outpatient. programs to help when it is available. However, we talked about how that's not uniform across the state. So having that as something to see as a potential possibility to see where that could be allocated. Crisis walk-in centers being alternatives as they're cheaper and individuals have a better experience than they would in an ER. And then we talked about how the navigators would kind of fall under promotion and recovery, where the co-responder models would fall under prevention and treatment. And then kind of overall, we talked about how things that are working seem to be more bundled and comprehensive. So they're kind of one-stop shop. So they're centers that can provide that comprehensive care. Having standards has been helpful as well. And so that was kind of an overall conversation. But yeah, if anyone wants to add anything, feel free.
Well, assessing for those arrested, assessments and screening at the time of arrest, if red flags are there, for juveniles and adults, so they don't all end up in jail.
Something stronger than already exists, as you mentioned.
Yes.
Anything else?
Well, and then before you move on, we may as well catch members of the public in the group since you were trying to capture them on the mic. Is there anything else you wanted to ask or public comment? We kind of blend our report out with that.
Okay.
All right, last group in the room.
And we have 2 on Zoom.
Yep.
All right, I guess it's me.
Okay, moving close to you.
So, following the instructions, we did start from the SAMHSA continuum. We got that far, but I don't think we really stuck to the script for the most part on these questions. In terms of the lanes in the resources here, I mean, the sections that we got through, I think there was a general agreement that some of these resources existed in some places of the state. There was a lot of conversation about disparity between urban and rural area capacity, a lot of conversation around disparity between people who typically access care through the safety net versus accessing care through the mainstream. A little bit of conversation about what it means to be a safety net, and are we really building a system that's responsive to the needs of people that aren't well served in the mainstream of behavioral health and health care. But we touched on the point that there really isn't very many examples at all of adequately resourced areas of the state. We then sort of moved into a conversation about systems and policy and how finance flows through different agencies based on federal and state appropriations and allocations, how even the regulatory framework is split between agencies, and then the actual system of support and referral is sometimes split. And so because, even categorically, public finance funding and policy isn't organized neatly within agencies, it creates a lot of opportunity for miscommunication among systems and lack of coordination. We spoke a little bit about whether truly coordinated integrated healthcare behavioral health systems existed anywhere. I don't think we answered that question. Possibly the VA, but probably not too many examples for general public.
We mainly took away that, what about thinking of safety as a system versus a provider?
Right.
And thinking of it differently than just a provider will do all things, and start thinking about it as a system where who's in charge of that, so whoever manages that system is accountable for making sure that there's an array of, there are enough providers to cover all the things.
Which
Absolutely. Go ahead.
I was just going to say, which adds implications for navigation, which we talked a little bit about.
So instead of having navigation exist between providers or groups that are the person entity, the system responsible for it is the one navigating. It's also responsible for making sure services are available. So you empower the person doing the navigation to make sure the services are there. We did immediately identify that mental health residential services is really lacking throughout the entire state, and that we absolutely need more medical detox services, not just social detoxes.
Anything else?
All right, we can go to Zoom.
Okay, let's move to Zoom. I'm going to sit down for this because I'm going to crank the speaker up. And Jessica, are you the reporter? I know you were the recorder.
I'm guessing so, unless someone in my group. Yes, I would say yes.
All right, well, we can hear you, so go right ahead.
So what we kind of talked about is that, like a lot of what the other groups have echoed, is that most of the services exist on the continuum, but in no way does that mean people can access them. They're timely. We talked about appointments being 5 weeks out, that even if a region identifies that they have the service available, that doesn't mean it's a close location to be able to get there. And then we spent some time focusing really on the crisis, that while the crisis system exists and it's made improvement, there are still really long wait times. And we talked about how one person kind of in order to receive crisis services had a 2-week wait limit, which doesn't help someone in crisis. And then even in the crisis system, that there's not enough facilities. There's only one facility on the Western Slope. Out in Eastern Colorado, we have to go to the Front Range for anything. We also talked about kind of in the continuum, there's definitely a lack of SUD services, co-occurring disorders, and those complex clinical cases, and especially in rural areas, that expertise needed for those clinical cases is not present, and there's no ability to reach out to maybe experts, or no centralized location to be able to reach out to experts to help with those clinically complex cases. The one thing we kind of identified as possibly a duplication is there's a lot of people doing case management, but no one's talking to each other. No one's keeping each other in the loop. I use the example of, we have healthy communities for Medicaid clients that will help connect clients, but then we also have the Ray care management team, and that has seemed like a duplication in our area. And as well as between mental health and medical providers. I know we don't have integrated care out here. One thing we identified that was working well was really the embedded teams within law enforcement. When they do exist, they really have seemed to make an impact. And then once we kind of talked about the lack of providers in rural areas, even though we may have had an increase in the state, rural areas still lack that, which kind of shows for the need of increased training for non-behavioral health care providers that are going to work with people who may have mental health issues, substance abuse issues. And then kind of one of, I guess, our solutions is the new Mental Health America report did just come out. And so we talked about how Rhode Island made a significant jump in that, and possibly looking at what did they do to have that increase. That's what I have. I don't know if anyone else in my group has anything to add.
Could you say the name of the report that came out?
Mental Health America report. Cody, can we move to you for report out?
Yes, and I'll give a really brief introduction for anybody who doesn't know me, because I'm just participating as a member of the public. But my name is Cody Hickman, and I work as an implementation specialist for the Department of Healthcare Policy and Financing, and specifically implementing findings from the cross-system crisis response pilot, which for anybody who doesn't know what that is, basically was a 3-year pilot looking at barriers to behavioral and mental health services for persons with IDD, intellectual developmental disabilities, both within the crisis system and then also just in the system as a whole. Or another way to look at it is opportunities for improvement. And so we obviously, or maybe not so obviously, but we covered everything that everybody else way more eloquently than I will state it covered. Some of the areas that we identified as specific pain points are such things as eligibility for services related to maybe diagnosis, or the confusion between whether or not persons with IDD or other specialized populations can have behavioral mental health diagnosis or needs. And if they do get a diagnosis, then access to services within their areas, like was mentioned on the Western Slope, or other areas that there just isn't a provider or specialty providers. Training opportunities for direct service providers or for facilities to help them essentially know that they can adapt their practices to serve specialized populations rather than looking for a clinical specialty or specialist. And then one of the areas that I heard brought up in a couple different, from everybody actually, is case management, care coordination. The fact that a couple years ago, maybe we didn't have an active care coordination role identified within a lot of services. But now we seem to see that phrase kind of inculcated in a lot of different programs, such as in the RAISE contracts or even in the crisis system or wherever. And that one of the things that we're hoping to see is as these things matriculate and develop, who takes the lead on that, and then who's going to be that granular on the ground navigator or Sherpa for connecting an individual to all of these services and getting everybody to the table and ensuring that they don't have a discontinuity in services when they do enter a crisis situation, things like that. We just really, I don't want to make it sound like we focused on gaps, but I think because we all on the Zoom work around individuals with IDD or other specialized populations, we tend to see the services as existing but inaccessible, and we're trying to find ways to essentially remove those roadblocks and barriers and connect them to these services in a way that will adapt them and allow individuals to get them in a preventative or proactive way, so that we're not just trying to create the best emergency system, but rather preventing emergencies.
Thank you, Cody.
Thank you.
Any closing thoughts before I ask one more time about comments from those members of the public that have joined us today? I think we have our work cut out for us. And our next steps trying to kind of pull all this together. Are there any other, on the phone, any members of the public that wanted to make a comment or ask a question of the subcommittee? Or those in the room? Yeah, I'll figure out a place to put it, or I'll just give you, I can pass out cards, and we're gonna put it on chat or on the Zoom so that people who are on the Zoom line can definitely send us their stuff, and I'll probably just pass out business cards. She was just asking how to get her, what she's typed back to me, and I'm just gonna give her my card. All right, so our next meeting is October 3rd. We're back at the Colorado County's building, which is the where we were maybe a month ago. Before we break, Nancy, do you want to give a 30-second explanation of parking at this building that you find helpful? Because that seemed to be a little tricky for us last time.
Okay, so Colorado counties that go there all the time, and the way I get there is I go west on 8th Avenue, right? 8th Avenue, and before you get to Grant Street, there's an alley. You turn into the alley, and there's a parking lot just right, you kind of just go right past the first building, the second building, and you just go right up. There's a kind of an above thing kind of parking place, and you just drive up there, and there's plenty of slots. And so it's open, you don't, nothing.
And there were lots and lots of empty.
Oh my God, there were only 3 or 4 of us who worked there here last time. So.
Yeah, but really,
all right.
The alley off the way.
Or Nancy?
No, actually, I don't work on my
We lost
we lost.
Robert's just gonna kind of close us out, and then you guys can go.
No, I actually like the small groups. I think we got really far, so I think we should continue with this model.
All right.
Yeah, they got really far.
They got really far.
Good.
All right, thanks everybody for your time.
Yeah. Well, really, it is.